Today we are presenting our next in our series on the UC CAI application webinar. And today we're going to be focusing on question number 9, which pertains to how the entrepreneur applicant has developed the strategy for the reimbursement plan for the technology that they're applying to the center for. Today's presentation is going to be provided by Marilyn Denegre-Rumbin. Marilyn is a JD MBA, and she is Director for Payer and Reimbursement Strategy for Cardinal Health. Marilyn has over 25 years of experience in the healthcare arena, from the hospital administration, practice management, healthcare contracting, and network development, spearheading reimbursement and payer strategy initiatives, in addition to consulting in pharmacy, medical devices, durable medical equipment, and emerging technologies. She's considered at Cardinal Health to be the subject expert on health policy, payer, and reimbursement strategy, and she's responsible for education, resources, analytics for strategy on health policy, health economics, reimbursement, market access, and payer strategy. So we're not going to be taking actual questions during the webinar. We would advise anybody who has questions to please direct those questions to their centers, administration and staff, and we will have you have the opportunity to receive answers from the centers in that manner. So with that, I'd like to turn the presentation over to Marilyn.
Good afternoon, everyone. I'm pleased that you're able to join us today. As Steve has mentioned, we're going to discuss the pre-market reimbursement strategy for new technologies, and that will be our focus for today. What I'd like to do is, with this slide, is bring to you the puzzle piece that is so critical in the early stages of integration for a product success. So this integration includes marketing, regulatory, clinical, and then the reimbursement. Many times what happens with new technologies or product development is that people work in silos, but it's very important that you don't. It's very important that it's very integrated, that there's a lot of good communication and input, so that as you move through your R&D process, that you complement each other, you fill in your gaps, and that you are making strides cohesively so that you save time and money. Reimbursement with the initial development of the product is that you're going to look at, you're familiar with your product design. Is it diagnostic versus therapeutic? That also would be very important because it has bearing on what's happening in the marketplace on health policy, reimbursement trends, and even what's transpiring with your payers. In your R&D, you must show the clinical value of your product or your technology or your pharmaceutical. And the reason being is that clinical value is what makes the determination on health policy. It also makes the determination on your coding, which we'll talk about in a few minutes, as well as what that reimbursement or the relative value units of your product would be. Your setting or your point of care is important. Is it an inpatient, outpatient, ambulatory surge? The trends are moving to more outpatient and post-acute care due to reimbursement trends. So what you want to make sure you're in alignment and how you're going to leverage that to maximize what you're going to need later on from a reimbursement perspective. And then, as mentioned, is that the different reimbursements actually will, in fact, be based on your site of care and whether they transition from one point of service to the next. Now we'll talk about provider type. Is it surgical or is it medical? Those also will be important aspects in your development, because you're going to frame your clinical value from that perspective as well. Is it based from physician or non-physician as to administering this product? How are you also going to target your patients? What are your classification or your population? And since reimbursement has changed dramatically for physicians, especially cardiology, orthopedics, oncology is changing as well, you're going to want to keep this in mind because of that setting of care that I mentioned earlier, and if whether or not a physician is going to administer the care, or is it going to be administered or facilitated by a non-physician. We had mentioned the clinical value earlier, and then I want to mention the clinical indications. You want to define the subset of patients, your population, the gender, the age, your disease states that you're trying to target. This is going to be very important, especially when you set up your clinical trials. With this, when you're building your project plan, I want you to keep in mind your market analysis. You want to keep in mind your market size, who are your demographics, who are you trying to target. It could be as defining whether it's urban versus rural and what you want to target that product. Your target price. This is where this is going to be very important in today's market because consumerism, especially with consumer-driven health plans, that pricing is going to be very critical in determining whether or not the insurance company is going to pay for it or it's going to be incorporated in a case rate, or is this going to be an out-of-pocket cost for a patient? In regards also to this target price, when you do your analysis for your relative value, and this relates to your coding, this is going to be very important as to whether or not you're above or below what is truly going to be reimbursed by Medicare, Medicaid, or commercial insurances. The other aspect of your market analysis is the current trends in disease treatments on populations. What I usually do when I'm doing an analysis from this perspective is I look at what's happening with the Affordable Care Act, what's happening not only in the United States, but in Canada, as well as in other global markets, as to determine what that trend is for the utilization of your product or technology. And then what are the disease treatments that these populations are looking at? Many times when I've done a beta project with a payer, I actually find out what are their 4 or 5 top disease treatments that they're looking at and the populations they're looking at. And am I in alignment? Would I be a good partner? Do I have an opportunity to do a beta project with them and collect data as well, which is we'll talk about later in this presentation? It's very important to understand what you're going to target and where those trends are so that you can maximize not only the reimbursement, but maximize that market access of your product. You're going to also do a competitive landscape, the competition mix, Companies, you want to look at companies, products, substitutes, like products. What else is your competition doing in the marketplace? How are they accessing from a coding, coverage, and policy perspective? You want to see if you can either piggyback off it. I do not recommend that you defame or bash the competitor. The reason being is sometimes there could be an early entry in the marketplace that you actually can piggyback and then look at the attributes of your product that either complement or offer an alternative treatment or utilization of that product that falls within the indications of the product acceptance by the FDA. Again, you're going to look at points of service. As I mentioned earlier, points of service, those trends are changing dramatically. Right now, CMS is trying to actually move products out of the inpatient into outpatient settings like home care, outpatient, post-acute care, SNFs. So you want to follow that. The other thing is even surgery in aspects. It's being moved into ambulatory surge. You'll start seeing that trend. So you want to see if your product is complementary into the 2 to 3, 5-year cycle of when your product will actually enter the marketplace. You also want to see what other products are in the mix. You want to see where that penetration is. You might want to do an overlap mapping of your competition. If you're already in a space, let's say if it's wound care, what's going to be your market share? Are you trying to capture 2%, 10%, 50% of that market share that your competitor might have with a like product or a competitive product? You want to figure out what that share will be, and then what is going to be your plan of action for access into the marketplace. In addition, you're going to look at and this is where all our puzzle pieces come in from a regulatory perspective as well. Your intellectual property is valuable. So your patents need to be, applications need to be timely and accurate. Your licensing. If there are aspects of where the best avenue, you know within your regulatory department that you have also your attorneys in place to guide you in this aspect without to ensure that you're maximizing licensing, patenting opportunities, that you have your trademarks and copyright. It's all in place so that there isn't any infringements. In addition to your regulatory path, as I had mentioned, review of the FDA application is very critical and early in the process. And the reason I suggest that you want to know what that product classification is it a class 1, class 2? If you have an opportunity to actually observe some of the application processes and to see what happens in the FDA review process, it's a great opportunity to see who's on the panel, get to know who the engineers and physicians at the FDA are. Cardinal was very lucky, they're fortunate, I would say, this past year, is that the FDA actually had an invite in the orthopedic realm. And with this is that all orthopedic producers were able to come in and show those at the FDA all of the products that they had approved and be able to have a hands-on feel, because many times all they see is the drawings or the specifications, but they don't get the hands-on that they really would like to with the product. So that's another opportunity to keep in mind if you hear of their, they usually have it monthly, a FDA review. It's very well received at the FDA, and it's really well received by those who are in a specific medical segment. The other is you want to identify the pathway for the FDA review, as I had mentioned, process and the approval. The time frame is very critical. Now, with that regulatory, I recommend that you do a SWOT analysis. You want to look at the strength, the weaknesses, the opportunities and the threats that might be taking place, not only with your product, but what's in the market. You want to know who you're going to have as your champions in the marketplace, whether it's a physician champion or a university, teaching university, or some other area that, in fact, you want to enhance and leverage for your FDA approval. You're also going to incorporate this process, which is really critical, and with your reimbursement. And you're saying, why? It's on the onset of my product. Why would I need to worry about it? As we mentioned earlier, that target price, the attributes, the clinical value are going to be critical as well with the FDA. One of the new opportunities that are happening with the FDA is to expedite products within the space. Is they're looking at certain products, treatment protocols, pharmaceuticals that might actually be able to be approved with the FDA. And if reimbursement is in place, they will work with the AMA for your coding and CMS on coding and medical policy. So this would actually save 3 to 5 years of market access if, in fact, you could coordinate this with the FDA to get your coding, coverage, and product approved at the same time. There will be, with your regulatory pathway, data requirements that are going to be needed. As you review the FDA application, you'll see what those data requirements are and what you need to actually have in place. Clinical trials and evidence are very important. I'll go into more detail about this later in the presentation, but you're going to have to show the efficacy of your product. You're going to have to show or demonstrate what the protocols are, what the advantages or attributes, what the contraindications are. These are very important with the FDA, but it's also important when you're in the marketplace because payers will look at this information. They want to know how this is going to be applied. CMS is becoming more stringent and I would say reserved in what they're approving for new technologies. So that's why you're going to have a very comprehensive plan, including clinical, regulatory, reimbursement, and marketing at the same time. Now we're going to start talking about the reimbursement pathway. What I usually do is define what the product is, services, the technology that is currently covered to do a comparison study. And this is not something in-depth, but it's just taking who your competitors are, looking at like technology, looking to see what the coding analysis would include. So if it's targeted for a CPT code, or is it a DRG, which is a overall case, or ABC, which is for ambulatory surge. But it also could include your relative value units, and these are very important at determining the value of a procedure, value of a product, and how they will be actually calculated for reimbursement. Next, as we had mentioned, is a coding application and strategy. If, in fact, when you're going through your FDA process, I want you to keep in mind that this is why reimbursement should be incorporated pre-market. And the reason being is you might need a temporary code. If there is not a code already approved by the AMA or by CMS, that you need to start your application process. And there's requirements involved in this. And so if you're going to go back to do a clinical trial, or you need to have to develop your clinical evidence, part of that is it needs to be incorporated into your coding application and your strategy. Now, what happens if you have to apply during this process for a temporary code, once it's in the marketplace, you'll have to apply for a permanent code, but you can't do that for about 18 months because you have to have a track record. And if you have to build the data necessary to show the efficacy and utilization of your product. So as we move through the presentation, I will elaborate on those time frames. Now, reimbursement assessment, as I mentioned, is very critical. It's probably more critical in the life cycle of the product than most people realize. So within that landscape, we're looking for with regards to a product or a procedure, we're looking at coverage. And coverage means what's that medical policy? What's the clinical evidence, application, and protocols, the contraindications and the indications for the utilization of that product or procedure. Coding, as I had mentioned, coding comes from both the AMA and CMS, and it defines if it's a product or a procedure, and that is actually very critical in order to bill. Your payment structure, that's your reimbursement. How will you be paid? Is this something that is going to be paid from your point of settings from hospitals? Is it from outpatient, post-acute care? All of that makes a difference on the reimbursement because CMS and Medicare, Medicaid, and commercial insurances all have fee schedules. They also have payment arrangements that if you need more detail on that from a contractual perspective, we can talk about that at a later time. The other is that because of consumerism and that this is how it is now driven for those who are in the marketplace with high deductibles and high is that there are a lot of constraints for people in the marketplace. So you want to make sure that that target price is correct and how you're actually going to be reimbursed from a product that might not be covered by another entity. Competitive landscape is important. actually to compare either like products or procedures that are in the marketplace. How are they being reimbursed? What is the traction on that? How is coverage and payment or reimbursement changes affect your product in comparison to your competitor? As I had mentioned, the legislative impact is changing dramatically on procedures. So we keep a target on that as to what those changes are with fee schedules, access. They have a tremendous impact. And what's new in the marketplace? There are some new legislations for new technologies that are coming out that are trying to expedite what's in the pipeline. The impact of the ACA has had a tremendous impact on the senior population. So we have to take this into effect, because what happens with not only the general population, but with the senior population, is that there are higher copays for them, and it can be more restrictive depending if they have a Medicare plan or a Medicare Advantage plan. Right now, too, incorporated with the ACA, CMS just came out with a mandatory bundled payment arrangement for joint replacement. This will have an impact. So if you're in the orthopedic sector, you need to look at bundle payment arrangements to see how, in fact, that's going to affect your product. Market access, as mentioned earlier, is how, in fact, you will penetrate the market. So where is your product? What's your demographic? What populations are you targeting? Your point of service. That strategy needs to be put in place, and then you have to work your plan. Partnering. Are you going to partner with a hospital, a physician? Are you going to partner with a product or a procedure that actually enhances what you're offering? So you want to look at that. Payers. You want to know what's going on with payers, as you've seen, which was on the horizon from the impact of the ACA, is that payers are moving to consolidation. To use an example, as you've seen, Humana, which leverages their Medicare Advantage program, is now merging with two other insurance companies, so that they're actually becoming more consolidated. This actually, in some ways, expands coverage or network access, but it also allows them to be in additional marketplaces that there had constraints in the past. Interesting enough, with payers, you're going to see more consolidation as the years go by. The other is you're also going to see consolidation, as the expression goes, single source payers and single source suppliers. So you'll see large companies also looking at their product mix, and whether it's medical devices, pharmaceuticals, but they're looking at product mixes, how to make themselves very strong, consolidate, and know what market space they're actually going to be incorporated in. The other is to keep in mind that I had mentioned partnering. You might also want to think about with partnering with large companies that have either a like product or will be complementary to your product. So I would keep that in mind too about partnering with larger companies. There might be some advantages to that as well. Keep in mind too that payment initiatives that are in the marketplace. I had mentioned to you about bundle payment arrangements. You're going to see a lot of gain sharing, value-based programs, quality programs that are going to be in the marketplace. You want to keep that in the forefront of your mind when you're looking at your product, that are you meeting those criterias that are helping to maximize reimbursement for a hospital or a physician. The other, as I had mentioned, is what's happening domestically within the U.S. markets, but also international markets and strategy have great bearing on what's happening here as you want to penetrate other markets. In addition, I want to comment, I have it here, investors will ask about your reimbursement strategy because they want to know how they're going to be maximizing or obtaining their investment and what those timeframes are, what your plan is, so that they know, what they're going to anticipate as well. So they will ask you about this, so this should be in place. I had mentioned to you before about the building blocks for a reimbursement, and that is coding. And as it outlines here, that classifies the patient's conditions, the services and supplies. Coverage also defines products and services that are eligible for payment. So if you have a negative medical policy, then it's likely you will not have coverage, which means that's going to be an out-of-pocket expense for a consumer or a patient. And payment defines the payment process and the amounts. So it comes from the fee schedules, payment arrangements that are made for through CMS, Medicare, Medicaid, and commercial insurance. You can have one and not the other, but it's optimal if you can actually have all three that are beneficial for your return on investment. Key understanding coding is that there are existing codes. I had mentioned this earlier, and then there are new codes which are required. You want to keep this in mind because if there's a new code, as I had mentioned, if you're in the process, for the FDA approval, you might need a temporary code. If there is already a code established and you're still going through the FDA process, that is a great benefit to you because it expedites your entry into the marketplace. There is a process with coding, as I mentioned, to do your applications. The AMA handles your CPT coding, and the CMS actually handles your HCPC coding. They will also, with CMS, handle the DRGs, and the APC coding will also come out of CMS. Coverage is in place, and I mentioned that's actually medical policy that outlines the attributes of your product as well as what the indications are and the contraindications are and what has been approved by the with your 510K from the FDA. With your coverage, they will demand data, especially the outcomes from your clinical trial. They want to see what the endpoints are. They want to see what the value is. They also want to see the value proposition. They also want to go back to the reimbursement. They actually like health economics involved in your coverage policies. It helps payers to determine the projection on building premium costs that they sell back to, or especially sell back to the employer groups, but they help to demonstrate to the employer group what that cost will be per patient per month. Your payment, is it, what you're going to be reimbursed adequate to support your pricing? You know, what are your margins in this? So that pricing, as I had mentioned earlier, the target price is really important. You're going to have to do your homework on this. And the thing is, you're going to have to do projections because what you do today can change in 3 to 5 years. So you have to know that costs will go up, pricing will go up. Interesting enough, fee schedules are going down. So you have to make sure that you have the right price point. And I do not recommend staying under the radar with this. You actually want to have a real economic analysis done on this, and keep it with tight margins is going to be difficult to maneuver as the years progress. Mentioned before, you'll hear this many times within coding. Again, CPT is how physicians are being paid for. A DRG, diagnosis-related group, is like a case rate, but they base it on diagnosis, and they give it a case rate for reimbursement. HCPCs are on products. We use them for DME products, technology, surgical equipment, that falls under a HCPC code. Again, that will come from CMS. Your relative value units are calculated. They're actually, the AMA is very good about having all of this available, all of the coding books available. 2016 is already available on the marketplace. They just had their AMA coding and RBVS meeting last week in Chicago, which released all of the 2016 codes, what the edits are, deletions, and additions. ICD-9, which you've heard is the disease, the coding for your disease and diagnosis codes. We're moving as of October of this year into ICD-10. The transition is in place. There hasn't been a backlash as they had anticipated. People are moving into that realm. And the reason being is that they want to use this classification because it was more universal and being used in international markets. This slide deck will also be available, and I noted here there are resources listed in the slide notes. So if you have access to this, it'll give you more detail describing each of the codes and those resources to access them. I want you to keep in mind when you hear and familiarize yourself with reimbursement terminology. Reimbursement methodologies can be complex. There are many variances. We're moving from fee from service to bundled arrangements, risk sharing, gain sharing, capitation. You'll hear a lot about that in the marketplace. You want to consider that in your reimbursement strategy because you want to see how you can complement your product with potential partners for distribution. Your payment systems, I had already mentioned to you, the payment systems are CMS, Medicare, Medicaid, and commercial insurances. There's also TRICARE, which is available for military. So that there's also insurance with Indian Affairs. So you want to keep that in mind depending on what your target is. Health policy falls into two realms. We have health policy that is legislative, and then we have health policy that falls into medical policy as well, that is integrated into your device and how it is actually approved or not approved for reimbursement. Then there's contract strategies. This would happen once, in fact, your product is in the marketplace, and there would be strategies of whether or not, if your product is something you're going to be able to bill directly, you will need to contract either with physicians, hospitals, or with payers, or all of the above. So that is something we would need to take a deeper dive on, but not necessarily today. What I usually recommend is there's 3 stages to your reimbursement strategy. If it's pre-FDA, we're in the pre-commercialization stage. And so these are the aspects that we need to keep in mind during that pre-approval FDA process. Your clinical study review, cost, coverage, coding, payment assessment, payer mix analysis. That also goes back to your population mix. You want to figure out, are you targeting a Medicare population, an urban Medicaid population, or are you looking at commercial payers where there's more commercial or consumer input from that payer mix? What are the payer insights? What are they looking at? How are they partnering? How are they handling risk sharing, gain sharing arrangement, capitation? What are employer groups actually pushing payers to contain costs and to manage disease states? And then you have your overall reimbursement strategy. Once you're approved by the FDA, you either have a temporary or a permanent code. You're then in the commercialization process. With that, we look at the coverage. That goes back to our health policy, medical policy aspects, coding. Do we need to, if we had a temporary code, move to a permanent code? What would be that time frame? It's anywhere from 18 to 36 months once you are in the market. It depends on your volume of distribution and how successful you are with your market access. Also, have you gained some champions that will help you with payers to actually have this product approved? The challenges too with payers right now is that they're actually looking to consolidate and manage their their approvals by selecting maybe just one product for wound care or one product for a treatment. So you want to know what payers are up to. So having that insight is going to be very important. Publication strategy, that it will go along with, putting your team together from a clinical marketing regulatory perspective. And that publication strategy is going to be important so that your product becomes not only known in the marketplace by name recognition, but also that it has the approval that you're going to need to actually have create demand for it. How cost effective goes back to that target price, but you want to make sure you're building that in. Your health care policy analysis, what's happening, is going to be very important. Are there more constraints in the marketplace, more exclusions rather than inclusions? What would you need to do to get a health policy or positive medical policy? Is there an opportunity to do a beta project with a payer to demonstrate the effectiveness and cost effectiveness of your product, not just the clinical aspects of it? That has been done to even get a case-by-case approval. We had already mentioned your code applications for a permanent code. I already mentioned advocacy, having physician champions or institutions that are championing your product. Goes back to your publications as well. How are you leveraging that advocacy? We mentioned payer communication. Salesforce training is critical with a new product. They have to know what the coding, cost, and coverage is. And the reason being, they're going to be asked those questions. So you want to make sure you have all this built into your entry into the market. You want to make sure you have your tools, a reimbursement guide that outlines your product. It outlines your 510K with the indications and contraindications. You want to outline what that coding and fee schedule is right there, right in front of you. So if they're speaking to a provider, whether it be a hospital or physician, they have all the information at hand so that they're effective in moving that product in the marketplace. Once you're in the market, you have a code, you have positive policy, hopefully, and the fee schedule actually falls in line with, or reimbursement falls in line with your projections. Then you're going to target payer activities for more inclusions. It could be through clinical education and training. This happens often with case managers, so I want you to keep that in mind. This is very important. If there's additional contracting opportunities, this would be part of your payer activity. You're going to track it. You want to maintain who your medical directors are if you do have access to them, and you want to track who's doing what in the marketplace, and you want it from a national, regional, and a local level. You want to determine what you might need to lobby, or where in fact reimbursement is changing or shifting depending on your product and the population. Maintain your health policy updates, advocacy, market updates, and of course your reimbursement landscape is changing all the time, so you want to see how you need to adjust your strategy with that. Really critical, and this is being required even by CMS and by commercial payers, though they have a lot of this data and they collect it. They're also asking providers and producers of technology, pharmaceuticals, to actually demonstrate and have the clinical data available. Any data on claims, on outcomes, very important. So you want to keep this in mind. Some of the programs that are going on with CMS, both prospective and retrospective, actually are looking at this not just on claims as to what is the outcomes of length of stays, whether or not there's infection rates, but they want to keep all of this data. It's very important for them to do their 3 to 5 year projections. You're also going to want to know, once you start if you're able to, you can obtain Medicare claim data. You can also obtain payer claim data. Keep in mind that Medicare claim data is 18 months old, and commercial payer is probably between 60 and 90 days. So you get a much clearer picture with a commercial payer with that retrospective data from Medicare, that lag time. You're going to have to cushion what the changes are from the fee schedule or the changes in reimbursement and what is then projected for the upcoming year. With your development of your payment strategy, you want, as I had mentioned earlier, you want to cover the cost of the procedure or the device for both the facility and doctor. We had mentioned the data. Economic data is going to be very important, as I had mentioned to you about the Medicare and the commercial insurance, because you want to see what coding they're using, what they were actually reimbursed. You want to find the points of service that come from that claim data. You're also going to find out if that is there an opportunity for additional coding once you analyze that claim data, that there might be an add-on payment if it's in an inpatient setting, and you'd have to apply for that unless the coding is already set up, but then you have to figure out what that add-on payment would be within the inpatient setting. The other is that if it's with the outpatient setting, it might be a pass-through. And you're going to have to find out how, in fact, you'll be reimbursed as with the pass-through status. Clinical data is going to be critical to substantiate the value of your product. So keep that in mind when you're developing your studies. You want to, ensure that you're collecting even the information on health economics as well as the clinical data, so it substantiates your value proposition. As I had mentioned with clinical studies before, you want to collect the high points to leverage the payment strategy. Primary endpoints, secondary endpoints, powered to show substantial clinical improvement over the standard of care. You want to demonstrate there's a reduced loss of stay. Do you want to reduce blood loss? Did you have an infection rate? Did you return with your ADLs that they were improved? This goes back to implants and joint replacements and such. Was there less pain post-operative? Faster recovery, reduction in payments. This is very important as actually the pharmaceutical aspects. One of the things with the bundle payment care arrangements that are implanted is that now with that mandatory bundle payment for joint replacement is that it's a 90-day window. So there are clinical endpoints that have to be added to this. There are looking at patient medication adherence, as whether or not a patient even adheres to their rehab. Very critical as to where your product will lay in that spectrum of care. And does it diminish costs? That is probably the biggest thing that everyone is looking at, how to reduce the cost of care and to improve the lives of patients. So keep that in mind as you are developing your products. Now, if you cannot afford to do an FDA study or a CMS payer study, you're going to need to gather a great deal of published data with the same goal as mine, to show and demonstrate the efficacy of your product, a cost comparison, improvement in care. All of that is going to have to happen in order for you to leverage the importance of your product, and that it's already in alignment with what's in the market, or it improves what's in the market. So you're going to have to come up with your strategy as to what that is. But in addition, even if you did your study, I actually recommend that you have a repository of the published data. And it's really important because you're going to find that if you ever have a discussion with someone at CMS or with a commercial payer, they do their homework. They have the repository on this data. on the published data. And they already have summaries on this, though they don't share it. But they're going to ask you very definitive questions, and you want to make sure you have done your homework, that you're able to respond to a published article or data that's out there, and demonstrate the difference between your product or procedure in comparison to what's in the market, to be able to gain some leverage. Payers have never covered really any off-label use, and I actually never recommend that off-label use. I know this happens a great deal in the military. They will do that, but they have a different system in place. But I would be very clear with my sales force or anyone else within the company is that it is not recommended, and it is clearly labeled what is off-label usage. The addition is that professional societies, your advocacy groups, will not support or endorse the technology without sufficient data, or if in fact you're promoting an off-label use of your product. So bringing the team together, again, keep in mind, you want to make sure that regulatory and marketing and reimbursement and clinical all come together, they work cohesively, they contribute, and that they're all following that project plan that you're put together. Because you're going to want to put together your economic value proposition, and all of those aspects that we talked about, all of those groups, marketing, clinical, regulatory, reimbursement, have to come together to have the same message and to build the economic impact, for the procedure to a hospital, to a physician, to a patient, or to a payer. You want to be able to communicate that clearly and intertwine all of the aspects that help to leverage your product or technology in the marketplace. You want to make sure that with that economic value, even though it might differ by customer, that the messaging is the same. You're consistent, and that your clinical value as well as your economical value are incorporated in your marketing materials. You're going to fill in the gaps. You're going to have a tight budget. All new products do. There's a lot of investment here. So you want to make sure that the outline that I've given you here, that you incorporate, because you're going to need to prioritize your studies because they're very costly. They can run into the millions. And you want to make sure that you set them up properly, that the data is collected correctly, and that you incorporate all the aspects I've told you. Everything you'll need from a regulatory perspective, clinical perspective, health economic perspective, especially for reimbursement. You want to know how you're going to be paid. And your investors are going to want to know how they're going to be paid later. They want to make sure that their resources that they're offering to you are being wisely used. I do recommend you develop a preliminary economic model built into your clinical study. This helps to identify if there's any gaps in the data, already available data, or what you need to collect to maximize your efforts with being able to go before the FDA for approval and then into the marketplace. And be critical. You need to really look at your model. You might even want to have someone come in and take another look at what your strategy is. Look at the strengths and weaknesses, where there might be some threats or opportunities. You want to ensure that, in fact, that the path that you've chosen, that you've collected, sometimes we become very myopic when we're in the throes of working with maybe a small group putting a product or procedure together, and we're excited about the technology, and we can sometimes lose sight of where there might be a threat or, in fact, some leakage or weakness in the process. If you can, we've done this in the past, you can develop a payer advisory board to determine what you would need. I do recommend this because they're always in an 18 to 24 month process. So if your product is ready to enter the market in 2 years, talk to a payer. Find out what they think what their projections are What disease states are they going to target? What trends are they looking at? See if, in fact, you're in alignment so that when you hit the market, you're ready to hit the marketplace. You're ready to go at a run instead of a crawl. So in addition to some of the payer advisory boards will actually bring self-insured groups in or large employer groups in to get their perspective on a product or procedure to determine whether or not this is advantageous to their employee population. There are technology assessment reports available. These are coverage policies for proxy devices. They can also support reimbursement and direction of coding and bundling. So keep that in mind as an opportunity to fill in some of the gaps. We had mentioned coding before. Review your coding requirements, background and categories, including the CMS and the AMA for requirements. They are available, but you also want to find there are consultants available who have been on the panels for CMS and the physician panels at AMA that can actually help you maneuver when you're going through the coding process. So you might want to leverage some of that as well. Start building your contacts. If there's a pass-through for payment, you want to find out what those requirements are, and if you need to apply for additional coding, or can you use coding that's already available. You will need to do an application for a DRG add-on, and that can be submitted as well to CMS, but you have to go through the initial evaluation first. CAMS's application for new medical services and technologies, they're looking for products that actually demonstrate quality, especially for add-on payments with the new hospital IPPS or hospital inpatient prospective payment system. There are now 132 new quality indicators that are under review. That in order for physicians and hospitals now to maximize their reimbursement, they're going to have to incorporate almost a good portion of them to get any gain sharing or payment neutral would be the at least, instead of having to be in the negative. So keep that in mind too when you're looking at your policy. What are some of the quality indicators out there? Look at value pay purchasing programs that are out there as well and being promoted by CMS. Very important because you want to be in alignment. You want to be able to figure out where you're going to align your product, your procedure, and complete your strategy. There are 4 key strategies for hospitals and physicians that are upcoming for reimbursement changes. If you can, develop medical staff hospital collaborations. This includes both private and employed physicians. In cardiology, what's happened is that you'll see that many cardiologists have moved under the umbrella of becoming hospital employees, and that is because their reimbursement has diminished dramatically the last few years, but their procedures are still well reimbursed. So hospitals have and physicians have collaborated on that arrangement. You're going to see more of that with other medical segments. So with the accountable care organizations, PHOs, as they were once referred to, but there's a lot of physician-hospital collaboration going on because of the changes in reimbursement and the demands being made by both CMS and the commercial payer. You want to develop an integrated and comprehensive continuum of specialty care. So if you're falling into that realm, you want to demonstrate where your product is integrated and how comprehensive it is in order to enhance within a specialty segment. I do recommend that you deliberately invest in and implement clinical and functional outcomes collection and reporting. It goes back to that data collection. Build it into your clinical trials if you can, is really very critical, but you're going to maintain that even at the commercialization and post-commercialization stages because you're always going to enhance your product, There are going to be changes in the marketplace. So you want to make sure you have a nice baseline and then be able to leverage what you need from a functional outcomes collection reporting. I had mentioned to you about the quality indicators. Again, define what that quality is in your product and how it is in alignment so that payers, and that's both Medicare and commercial and Medicaid, because there's Medicaid commercial managed care now, they also have quality indicators involved in their reimbursement. And then you know what you have, you've done a comparison to demonstrate your value, how you're in alignment with the quality indicators that they're looking with, and that you're going to be a good partner. That's also an opportunity for you to leverage with the payer for maybe some demonstration or beta reimbursement models that are on the horizon. CMS is actually looking at, through the healthcare payment network. It's a consortium of all the payers and those involved in technology that are actually looking at this network and building new payment models that will be in the next 3 to 5 years. So keep that in mind. And then, of course, your plans for your project funding. All of what we've talked about actually is very important for your project, but your funding is going to be important too, because you're going to have to know what your costs are. So you're going to have to identify and quantify the needed funding. You're going to have to figure your pre-FDA, your project plan is usually 3 to 5 years before you're into the market with the FDA, unless you can expedite your clinical studies. But primarily, both payers as well as, especially payers, I would say, actually are demanding 3 to 5 years of clinical studies with a health economic impact to determine whether or not they're going to give a policy. So you want to make sure that reimbursement is really there, especially later if you have to go for coding, collect it in the beginning. Post-FDA, this is your commercialization stage. Early market entry, if you're lucky. For coding, 18 months minimum to submit your application, another 18 months usually for approval. It is rare to get a new code under 3 years. I've had the opportunity that has happened with a company that we were able to do this because we did incorporate the reimbursement strategy early, and the data we were able to collect once we were in the marketplace, we were able to get a permanent code in 18 months, but it's very rare. So keep that in mind, that 3 to 5 years. You want to build that into your project funding because you're going to need that for your administrative staff, sales force, clinical, regulatory personnel. You want to be able to project, their salaries, benefits, and costs involved in keeping this project before you are out of the red and in the black. You're going to look at, with your project funding, what might be some of the constraints, potential leakages. You actually have to look at what's going on in the marketplace. If you're in the U.S., what's the base of our U.S. dollar? What's happening with financial areas in the world? Are they contracting? Is there recession? Is there growth potential? You want to keep this as part of your project funding. So you want to know whether or not you need to build in a cushion. I actually do recommend you budget and plan for a rainy day. You don't know if you're going to have to go back and do another study. Did you miss something? That rainy day might be there. You might have to hire a consultant to help you in another aspect. There might be something that happened in regulatory, or you want to be able to make sure that you're cushioned. Assess the resources that are available, grants, investors, additional partners. See what else you can leverage to actually expedite your product and support it in the marketplace. And then most of all, I recommend you develop your value proposition messaging. And it comes from all of your groups. And actually, as I mentioned to you before, that value proposition comes from regulatory, clinical, reimbursement, and marketing is the one who puts it together and packages it. And you want to make sure you're consistent in what is being communicated out there. Moving forward, I want you to keep in mind healthcare reform will continue to evolve. You're going to see contraction in the marketplace, consolidation. Be aware of that. There's opportunities there. There are times to figure out what your strategy is so that it complements what you're trying to do in the marketplace. Where that opportunity is to partner maybe with another product or a procedure or a point of service that you hadn't considered in the past. But healthcare reform, with the changes in legislation and policy, there are opportunities available. There are opportunities for innovation, especially innovative products focusing on preventive services, showing a reduction in hospital costs, emphasis on primary care. That's there. The other is you're going to see what it is in bundling services as well as products together, because they're going to be, especially from CMS for the Medicare population, there are going to be constraints. So what product or service are you offering that helps to reduce cost, increase care, and become a good partner? You will see increased price pressure from hospitals and physicians because of the contraction in fee schedules and reimbursement. I will reiterate again, reimbursement must be factored into early product design and integrated with regulatory and market development. Lack of reimbursement will limit your market acceptance to innovative technologies despite clinical value. So please incorporate this in your plan. Again, develop your project plan, track and assess, and work your plan. I want to thank everyone for their time today, and Steve will then give our conclusion to this presentation. Thank you, everyone. Have a wonderful day.
Thanks very much, Marilyn, for this excellent overview of all the complex issues that need to be considered in developing the near-term and long-term successful reimbursement strategy for healthcare products. So those of you who have questions, we will not be taking questions here. I would encourage you to direct your questions to your center administration or your site mentors and advisors in the CAI program. Thanks, everybody, for being with us.